Well, good afternoon, everybody. Welcome to this webinar series on mental health and COVID-19. My name is Alberto Vázquez. I work at the Office of the UN Special Rapporteur on the Rights of Persons with Disabilities, and today I will be moderating this discussion on human rights and mental health in the times of COVID-19. And as we have seen, the impact of the pandemic on the mental health and well-being of the population is getting significant attention by the international community. Recently, the UN Secretary General issued a policy brief calling to prioritize mental health and psychosocial support in the post-pandemic process of building back better. However, what seems to be missing is a discussion on the quality of the services and the support needed, and the human rights implications of maintaining the status quo of mental health provision. So critical voices from users, survivors, people with psychosocial disabilities and their experience have also been missing in the global discussion. And this is what we will try to talk about today. And to do this, we have a terrific panel. We have Akiko Hart from the UK National Survivor User Network. We have Shantha Barriga from the Disability Rights Division of Human Rights Watch. We have Innocentia Mgijima from the Disability Unit of the Center of Human Rights at the University of Pretoria. And finally, we have Dainius Puras, the UN Special Rapporteur on the Right to Health. So thank you all for being here with us. Before we start, I just would like to remind you that this session is being recorded. Please feel free to tweet during the session. We're using the hashtag COVID-19MH, and the session will last 45 minutes and will be followed by a discussion on Twitter that you can join for another 15 minutes. So let's start this discussion with Akiko. Akiko, tell us what has been the impact of the pandemic and the lockdowns in the user survivor community in the UK?
Thank you very much. So much of the focus during COVID-19 has been on the mental health and well-being of the general population. What we've heard less about is how the pandemic might be affecting people who live with mental ill health, distress, or trauma. And from what we're hearing in England, the picture is really mixed, and I really want to hold on to that diversity. So some people are managing to access support or services that are useful for them. Some people are not. They're being discharged early into non-existent or severely depleted community mental health services, or their routine appointments are being cancelled. And for other people, the pivot to digital has been really mixed. It works for some people, it doesn't work for others. It kind of depends on the context. Is it an appointment, therapy, peer support? I think a lot more work needs to be done around digital and who it excludes. If we look more broadly at the situation in England, we can also see how COVID-19 is highlighting inequalities. There's been anger and dismay in the UK over the disproportionate number of COVID-19 deaths of people from racialized communities. What is perhaps less talked about is the collective trauma experienced. The collective trauma of seeing the consequences of racialization and systemic racism in action that is then denied by the establishment, who might talk about disparities or the need for more data, more action, more inquiries. It's a really powerful example, I think, of how mental health is inherently political, that mental ill health or distress can occur and be maintained by a series of political actions and choices, and how these issues of race, whiteness, and racism need to be centered in mental health.
Well, that's interesting, because what you're highlighting is the impact of the pandemic in the inequalities that people was already experiencing before the pandemic. And this is linked for the second question I wanted to ask you, in terms of, as part of the government response to COVID-19, the UK government modified the mental health and mental capacity legislation. And what has been the impact? Why the user survivor community opposed this reform?
Okay, so the Coronavirus Act proposed legislation to relax safeguards in mental health legislation, amongst many other things. It's important to note that these changes haven't been switched on yet in England and Scotland, and that some of them have in Wales and Northern Ireland. So it's a little bit of a mixed picture across the four nations. So some of the proposed changes include an approved mental health professional securing advice from one doctor instead of two in order to section someone, Forced treatment beyond 3 months being possible without getting an independent second opinion, a SOAD, if it's deemed impractical, and some of the time limits in the mental health being extended. So, for example, Section 5, which is normally 72 hours, being extended to 120. And the rationale for the legislative changes was the anticipated shortage of doctors who could make recommendations for detention under the Mental Health Act, and a likely reconfiguration of the mental health estate to create space for additional beds. However, as I said, these changes haven't been switched on yet, and I'm not sure that they will be. And in a funny way, I don't actually think these changes were particularly well thought through at the time. I don't think they help with the stated problem, i.e. this potential shortage of doctors, but I think what we might see instead is they are switched on because of a rise in admissions, because of a rise in distress. Yeah, and if that happens, that's absolutely something we would be needing to look at and challenge from a rights perspective.
Thank you. Let's go to Innocentia. So there has been a lot of reports of high rates of infection and death in social care institutions and psychiatric hospitals around the world. But what's the situation in the African region?
Thank you, Alberto. So the uneasy truth is that we actually don't know. We are aware of confirmed cases of infections in a number of institutions. So, for instance, the Accra Psychiatry Hospital confirmed that one of its patients tested positive for COVID-19 in April. But apart from these isolated reports, there is no official data from government on what the magnitude could be. And this is really concerning, but I think it also, it suggests a lot. The absence of data actually suggests a lot. So firstly, it suggests that our governments are actually not monitoring the situations in institutions and psychiatric hospitals, and that this is not unique to the context of COVID-19. It also signifies the priority that is given to a collection of data and information concerning persons with disabilities. So just to put this into context, for instance, African countries like South Africa efficiently collecting information on infection rates in correctional facilities. So, and they're doing such a great job that we know as of today there are 1,021 cases of infections in our correctional facilities. We know there are 3 deaths. We have no idea what's happening in institutions. There's also the possibility that governments do have this data, or at least some data, and that they are simply not publicly, or proactively making it available to the public. And I think this speaks to really a greater challenge on the continent around, the public being able to access data that government has collected. What we do know from the Disability Rights Monitoring Survey, which I'll speak to a bit later, is that the situations in institutions is deteriorating in a number of countries, and that the risk of infection is high unless we do something about it.
So tell us a little bit more about this COVID Disability Rights Monitoring Initiative. You're part of it, the University of Pretoria is part of it. So what are you doing and what have you found?
Okay, so it's a global initiative that was started by 7 organizations that work to advance the rights of persons with disabilities globally. A list of the organizations that are participating can be found on the Disability Rights Monitoring website. What we've been doing in the last few months is really trying to collect both quantitative and qualitative data through an online survey on what has the impact of COVID-19 been on persons with disabilities, their families and their organizations, but also what are some of the measures that that governments have put into place to ensure, to protect the rights of persons with disabilities during this time. We've also started sharing some of the preliminary findings of the data on the website. So we have over 1,600 responses to date from over 126 countries. 10% of those responses are from African countries. the majority of the responses have been from persons with disabilities themselves, their representative organizations, as well as family members. So what we're finding globally is that there is a failure by many countries to adopt a disability inclusive approach to the pandemic. And specifically in terms of the discussion we're having today around health and COVID-19, we find that the measures being taken by government are inadequate in terms of really trying to ensure and protect the health, life, safety of persons with disabilities, particularly in institutions, and particularly vulnerable groups in those institutions like older persons and children. So what government's response has been to this issue has been primarily sort of restricting and banning visits to institutions by family, friends, or other people, restricting people from leaving institutions, so persons with disabilities from leaving institutions, restricting new admissions into institutions, and also committing actually new people into institutions, particularly homeless people with psychosocial disabilities. But that has been the extent of the measures and not anything beyond. So some of the human rights concerns that have been raised in the responses we're getting is that this isn't adequate. So government isn't actually providing, the clear guidance to institutions and also the support institutions actually need during this time in order to cope with the pandemic. So, so of course, this differs in degree and manner across countries. But what we have found is that, several responses indicated that, government didn't provide clear protocols or regulations on how institutions should be, handling the COVID-19 pandemic. So where regulations were provided, they were not clear. They are a lot, they're constantly changing. They are quite, generic or general in nature. They don't really speak to persons with disabilities and the specific issues. And so because of this, a number of institutions have then, started making up their own rules and regulations on this, and some of these are actually quite arbitrary rules and rules that infringe on human rights. We've also noted that governments have not been sufficiently supporting institutions, particularly under-resourced institutions. So this is particularly true for low-income countries where, institutions were not being provided with, personal protective equipment, food aid, medical aid, medicines, and a number of other supports that they need. And where government was providing support, it wasn't equal. So we've seen inequalities between support being provided to urban institutions, vis-a-vis those being afforded to rural institutions. But I think there's a number of other issues as well that have been raised: access to independent monitoring mechanisms, access to health services, access to information is one of the persistent problems that's been raised through this, through the surveys.
Thank you. Let's go to Shantha. Shantha, so there has been also a lot of discussion about the situation of people in institutions, but it's true that there is less attention paid to people with psychosocial disabilities or intellectual disabilities who are shackled and locked up in their own communities. So what information have you been able to collect during this outbreak?
Yeah, Innocentia mentioned that there's very little data even on what's happening in institutions, and it's even harder to get that data about what's happening in communities. Human Rights Watch has been working on this issue of shackling, where people with psychosocial disabilities are either chained or confined in small rooms. And we found that this happens across the globe. There's tens of thousands of people who are in this condition simply because they have a mental health condition. And when you see this yourself, you just can't believe that anyone is treated so inhumanely. They're invisible to the data, they're invisible in their communities, tucked away. I mean, frankly, they're not even considered equal human beings, let alone enjoy human rights. To give you a picture of what that's like, we visited traditional healing centers, spiritual centers, even psychiatric hospitals in some countries, so-called rehabilitation centers, where we found In Nigeria, for example, 300 people in one religious center lined up, as young as 10 years old and as old as 86 years old, all of them chained and in close proximity to each other, overcrowded, let alone have any kind of social distancing. Hygiene, there's no soap and water. The conditions themselves are very unhygienic in the facilities. And how can you expect them to actually protect themselves from COVID-19 in such an environment? They often don't even get access to healthcare in normal times, let alone in this particular pandemic. We have found our partners actually in Indonesia, it's led by the Indonesian Mental Health Association, have started doing testing in some of the institutions, social care institutions in Indonesia where people are shackled, and they have found cases, but it's just the tip of the iceberg. And what we need to see governments doing and the heads of these facilities doing is making sure that people understand what COVID is, that they have access to good hygiene, that they're not forced to live so close to each other, they have access to healthcare. And there isn't all bad news in Ghana. We were working very closely on this case and following this case that was in the psychiatric hospital back in April. And we also have a number of great partners there on the ground who are monitoring informally some of these spiritual healing centers where people are shackled. And we found that at least in some of them, people are being released from the chains and back into the community, in part because of the pressure from all of us, but also because of COVID, just a very practical reason. But on the flip side, you can release the people from these closed facilities, but if there aren't the services ready in the communities to support them, their families aren't ready, they themselves don't have the supports that they need in order to thrive. And so it's still a very difficult situation. There just needs to be more investments in community services that are respecting the rights of people with psychosocial disabilities.
And from the work you're doing in terms of monitoring the human rights of people with disabilities, including people with psychosocial disabilities and intellectual disabilities around the world, can you speak a little bit more about the intersectionalities when it comes to mental health and human rights?
Absolutely. I think there are two areas that really strike me. One is gender, obviously. We've been hearing how there have been increased number of women experiencing domestic violence as a consequence of COVID, people forced to stay home, people under a lot of stress with economic pressures because of lost jobs, et cetera, which has led to an increase in domestic violence. What we haven't seen a lot of is that women with psychosocial disabilities and other disabilities are particularly vulnerable to this kind of domestic violence. And we actually released a report last week on Mexico and looking at family violence and abuse against people with disabilities by the very people who are their caregivers. And you can imagine there's a real tension there because those people with disabilities are really relying on their family members to help them do daily things like have their meals or take a bath. And yet, in this context, they have really very little leverage in order to report on abuse, especially the added trauma that's associated with, as Akiko mentioned, the trauma associated with this lockdown and the isolation. We actually documented a case in Mexico of a young woman who was at a residential school and for people with disabilities and was sent home as a result of COVID. And she was sent home to an abusive environment. So now she is here trapped inside a home where her parents are abusing her. And that's, the consequence of the lockdown and the impact that has and the trauma that it's going to cause her because not only of the abuse, but also being locked together with the very people who are doing that abuse. The second intersectionality, sorry, I'll mention, Alberto, is in terms of race. Because, and Akiko mentioned this briefly as well, especially in the context of prisons. If you look at the population of prisons, the majority of the population are people with disabilities. Many of them are people with psychosocial disabilities. And many of them are people with psychosocial disabilities who are indigenous or people who are Latin American or African in the US context. It's really striking to see how these layers of discrimination build up. And in a prison context, particularly, again, social distancing is almost impossible because in many countries they're overcrowded and they're unsanitary conditions. And then when you add to that some of the punitive measures like lockdown, which further aggravates trauma and mental health for people, anyone who's in a prison. And when during these lockdown situations, people with psychosocial disabilities in particular, we've done research on this in Australia, for example, they're more likely to be bullied or harassed for food or medication. They're more likely to experience physical or sexual violence, especially under lockdown, where there may be as many as 20 hours that they spend in a small shared cells. They often don't have access to mental health services, and they're dependent on others, and there's just a lot that needs to be done to make sure that prisons outbreaks are minimized. And that means that governments need to release prisoners who are detained for exercising their basic rights, who are detained without charge, which is often the case of people with especially intellectual disabilities, but also mental health conditions, or for low-level or non-violent crimes. And also older prisoners or those who are more at risk of getting COVID should also be considered for release, because we really need, there's a huge intersection there when it comes to race and poverty and gender and disability in the context of prisons. That is, again, because it's behind closed doors. You were mentioning in Innocentia that there's more numbers on in terms of what you're seeing in Africa, but we still don't have a full picture of what's happening in prisons across the globe, and in terms of people who are in there who already have mental health conditions or who experience them as a consequence of getting into prison.
Thank you, Shantha. Dainius, so I mentioned at the beginning, there seems to be a growing awareness on the mental health impact of the pandemic. But the question that I keep asking myself, but also that I keep receiving, is how can we promote the mental health and well-being of the population and at the same time avoid medicalizing normal responses to stressors?
Thank you, Alberto, and thanks to organizers for this very good and timely webinar. Yes, this pandemic activates all important questions, all human rights, including the right to physical and mental health, which is my mandate. And one of issues which is discussed now, shall we go on in the same way, which I call status quo? So shall we invest in the systems which exist, or shall we rethink? And if we rethink, we need to try to understand that these are normal reactions of people when they are anxious, when they are afraid of uncertainty, when they are obsessed of being infected. So shall we tell people to go to mental health services and to get medications for this? Because it may happen. In many countries, the only way of reimbursing mental health services is psychotropic medications. And so this is one of things which I think it's very timely to discuss again, that we have gone globally too far to biomedical model of managing both common mental health conditions and psychosocial disabilities. And this pandemic, I think, not so much fuels prevalence of mental illness, is what I'm reading in some papers. No, it may fuel wave of over-medicalization and obstacles for change, which are overuse of biomedical model, power asymmetries between service providers and service users, and biased use of evidence and knowledge. When textbooks still in the textbooks we can still read that depression is because of chemical imbalances and so on. So this is good opportunity. This crisis is good opportunity not only for mental health and human rights, also for physical health and human rights. Not to totally change the system, but to address imbalances which were happening during recent decades, and to stop this vicious cycle when promise was to reduce stigma by biological psychiatry, but actually many people were disempowered by this message that this is just something happening in your brain. So I think with these effects of these pandemics, we can have some sobering messages to policymakers, politicians, and to professional groups. And I think that professional group of psychiatry also can rethink some of their positions.
So we know that what is coming now, when the lockdown start to get, I mean, we're seeing the easing of the restrictions, and things are going back to something new, but let's say normality, and the focus is going to be now the building back better. What the states can do in terms of investments, especially taking into account your new report on mental health and human rights that is going to be presented in June to the Human Rights Council. So which key message you will take from that report that should be included in the Building Back Better?
First of all, to address mental health and human rights in more broad context, because as we know, mental health especially is linked with all human rights, and both economic, social, and civil, political, and cultural. And if we know that to have good mental health, we have to invest in enabling and supportive environments, starting from family, then schools, workplaces, but also mental health services should be free of violence, free of humiliation, and free of forced measures. So this is what we call human rights-based approach, and the same and mental health policies should fully embrace mental health, a human rights-based approach, and not in selective way. Selective ways when people tell that right to mental health is to get treatment. Let's reach everyone and give treatment. This is not enough. Let's reach everyone so that everyone is free from violence, ill treatment, torture, including in mental health services. So this is the main message about the role of social determinants of mental health, discrimination on all grounds, violence, inequalities, and poverty. These are main killers or main risk factors for mental health. And pandemics and the effects of pandemics can go both ways, can increase these risk factors, and can reduce, and everything, not everything, but much is in our hands. What messages we send to international community, to governments, and I had very interesting months as a member of special procedures, as a member of coordination committee. I was working with other mandate holders, because all human rights were activated, as you know, during pandemic, and we were working with Human Rights Council, with governments, of course, in remote, in virtual way, to convince that there is no conflict between right to health and other human rights, during pandemics, because there were some attempts to disconnect human rights from saving lives. Human rights-based approach is crucial. During AIDS epidemics, human rights-based approach is crucial now during this pandemic, and we have to send very strong message. And I could see some hopeful some messages from governments were hopeful. There was some understanding, for example, that we need multilateralism and some understanding that we should go finally to revitalize universal human rights principles, which was under attacks for last years. So I am maybe too optimistic, but this crisis may have healing effect to humankind. You know. And mental health cannot live without this. If other human rights are, violated, how can we expect that only persons with mental health conditions will be respected?
Yeah, and for me, there is another opportunity that I see there in terms of peer-led initiatives. And I think during this crisis, I have been following really the work of the National Youth and Survival Network in the UK, and I have been reading the amazing pieces that have been published. But I know, I mean, the recent one on racism has been a very strong piece from Jayseri. But I would like to learn more or to listen a little bit of briefly about the experience in terms of peer support, because I know the movement has been very active in the UK during this time. Akiko, yeah.
This is me. Yeah, it's been a really interesting time. I think at a kind of policy level, there's certainly been a lot of people saying things need to change. This is an opportunity to do things differently going forward. So the rhetoric is there. I don't know how much of it is just words and how much of it will kind of filter down into action. But it's interesting that people are talking about mutual aid, for example, because there have been so many mutual aid groups kind of springing up across the world, and about peer support. And just as an aside, I should say as well that one of the things that worries me a little bit is that, on the one hand, we've seen a huge amount of mutual aid, kind of peer support, community, grassroots initiatives kind of springing up because people are supporting themselves, basically. But on the other, these are initiatives which have been chronically underfunded over the years. And even though there's an awful lot of COVID-19 money that's kind of around and that's available, yeah, it's only really available for quite established charities, the third sector, or quite big organizations. The money just does not filter downstream. And I think that there needs to be a real kind of paradigm shift in terms of how funders as well as governments think about how that money gets to the ground. So yeah, peer support has been, I've been involved in some really exciting conversations over the past few months around peer support online. And what I can do in the chat on Twitter afterwards is kind of link up to a few people who are leading some of these conversations, because all of a sudden it means we're not just talking to people, in our kind of town or area within our town. It becomes an international exercise, barring the time zones. And there's something incredibly exciting and encouraging about it, but with challenges as well, because obviously online isn't always safe, doesn't always feel safe. How do you create safety online? These are really big questions that I think we need to think about if we're going to move some of this stuff online.
I want to do a final round of interventions. So I would like to ask all of you to answer in 1 minute or two, what would be your top priority action to guarantee the human rights in the mental health provision and human rights of people with psychosocial disabilities in the COVID responses? What will be the top priority for you when we talk about human rights, mental health, and COVID-19? Innocentia?
So just thinking of the context of Africa, like I pointed out earlier, I think it's really important. as an urgent measure that governments actually start monitoring the human rights situation in institutions, that they provide the necessary support and oversight that is needed to ensure that human rights violations don't take place, and to obviously send the message that mental health and human rights, it's a priority to our country. So I think that would be the first. I think the second one is that we really do need the qualitative and quantitative data on these issues to inform policies, for us to clearly see where the gaps in protection are. And so there's really need for collaboration between academia, organizations of persons with disabilities, and government to collect this data, but also to then use this data to make a more informed policy and other responses.
A follow-up question: in the Disability Rights Monitor, did you get data directly from people with psychosocial disabilities, or do you think there has been an underreporting directly from people with lived experience?
So in terms of psychosocial disabilities, we have received some data. We've even received data from people within institutions. Of course, it's a small percentage compared to other impairments that are represented. But I think this speaks to the need of really finding more accessible ways of getting to this particular group and making sure that they are participating. And how do we change the modalities of some of our surveys and how we get information.
Thank you. Shantha, your top priorities.
Yeah, I would echo what Innocentia said about monitoring and so on, and even what Akiko talked about peer support. But I would say, I think there's a moment now, I'm actually quite hopeful, where people have experienced a bit of isolation. They understand how that's quite traumatic for our own mental health, and maybe they have a little bit more insight, a little bit more empathy than they had 6 months ago. But in this process of building back better, I think people want to know, well, how does it work? What does it look like when you have a rights-respecting mental health service in the community? What does it look like when we don't forcibly treat someone or admit them in a hospital against their will? Because they can't conceive how it can work, because they have never seen such a system themselves, and they can't even envision that it's possible. And so I think what's the #1 priority is to develop these solutions and to highlight them, amplify them, programs like the peer support that Akiko talked about, but other initiatives, so that people can see how it can work and scale up those initiatives. But we need to see more solutions, because I think we are all very clear on what are many of the problems, but we don't have a lot of good examples that we can point to and said, but they're doing it here and they're doing it there, and look, it works in the north and it works in low income settings. This is what we should build our system back better, looking like this. So that's where I say we need to invest, is to invest in these solutions, so that and highlight them to policymakers and to the public, so that people can start to envision what that system looks like when we respect people's rights.
Thank you. Dainius.
Well, two things. One is about mental health of everyone. I'm very passionate about universal human rights principles, and that this is like vaccine. This is, best way of protect mental health of everyone. And after this regress with different kind of traditional family values and so on, and not allowing adolescents to receive sexual education in many parts of the world, how can we expect good mental health of people? So and again, I am hopeful that it will be revitalization of the best what global community has. And with regard to within mental health services, I think that we need now another strong movement or wave to go to the institutionalization, after one more argument we have now, that institutions are harmful. They were harmful already before, but we see now how wrong is the idea to keep people closed in some artificially created places and dehumanized places, and to keep investing in these, buildings. So I think that we will have now stronger movement to go to community-based services and not to trans-institutionalization, what is going on in many parts of Europe, for example, just playing the game, building smaller institutions instead of big institutions. This is not about dignity of people and not about effective way of investing in mental health and human rights of persons, children and adults with disabilities.
Dainius, and this push for digitalization, which is true, I think this crisis is showing the importance of moving in that direction again. But I think, the case has been built for children, the case has been built for adults with disabilities. So how do you see is the next steps in terms of older people? Because it seems to be that long-term care is meant to be institutions for older people, particularly people with dementia that have been particularly affected through the COVID pandemic. So do you think there is an opportunity there also to move in this direction with the older people community?
It was one of very hard talks when I was having consultations with different organizations. I was asking about what people think about homes for old people. And now I regret a little bit that I was, as mandate holder, not so tough and did not go this to send a very clear message, because some organizations were telling, why do you want to discriminate old people? Old people deserve the same to live in community. Why you want to close them in special homes? So I think we have to apply the same principles to everyone, just to be very creative and innovative about how to create this enabling environment to people with dementia, for example, in community settings, but they have the same right to live in the community.
Thank you. Akiko, the top priorities.
Yes, so everything everyone's already said, of course. Perhaps something around process. So if we move away from this idea of kind of service user or user involvement, and we start to think instead about leadership, and if we move away from this idea that disabled people or people who use services or people with lived experience are one set of stakeholders amongst many, okay, and therefore everything needs to be balanced out. And if instead we move to a situation where their needs and their rights are centered, and also if we perhaps kind of stop just seeing it as individuals with individual experience, but start thinking of it as, collective knowledge, collective survivor knowledge, then I think that would change the way things are thought about and decisions are made, and that might lead to some different outcomes potentially.
Thank you very much to all of you for this amazing panel. For listening to you, for me, it's clear that we cannot talk about mental health without talking about human rights. And as Dainius is stressing in his last report, which I would recommend everyone to read, the most glaring gap is not really the treatment gap, but the lack of rights-based approach in mental health systems. So I think what we're discussing here is how we take this opportunity to rethink mental health provision and to ensure that investments in mental health as part of the Building Back Better are community-based, user-led, and free from coercion. And I think the World Health Organization Quality Rights Initiative can actually help governments to move in this direction. So thank you again to all the panelists and the organizers and those following us for this discussion. The recording and the notes of the session will be posted in the website of United for Global Mental Health very shortly. We will now continue the discussion online using the hashtag COVID-19 MH for another 15 minutes or more. And the next session will be on June 16 at the same time, and it will be about stories from the field, ensuring continuity of mental health care during COVID-19. And people can register at the website of United Global Mental Health to join and submit the question in advance. So thank you, everybody, and have a good afternoon. Goodbye.
Thank you.
Bye, thanks.
Thank you.